Absolutely ready.
Okay, then okay, sure. I'm starting. Okay.
Can we start, please? Someone, please do let me know on the live chat. Hey, Dr. Vishnigam. Good evening. Good evening. Good evening. So glad to be with you yet again. Hello, Dr. Vikram. B for Vikram, right? Nice name, buddy. We'll wait for a minute or two and then we'll start. Now it's there. Dr. Helpful, Dr. Nishali, Dr. Mahi, Dr. Johar Ali, Dr. Shankar Chaudhary, Dr. SBR 12, Dr. Shama Sheikh, Dr. Kartike, Dr. Manoj, Dr. Mahesh. Glad to be with you. Hello all. Dr. Jasjeet, Pradyumanji, Sandhya Suresh, Dr. Harry, Dr. Shankar yet again, Dr. Kaushal Prajapati. Wow. Penza. That's great. Dr. Harry, Dr. Prerit Sisodia. Hello, buddy. Yeah. Thank you. Thank you, Dr. Vish. Hello, Dr. Priyam. Oh, God, Priyam, we are connected yet again. I'm just about fine, buddy. What's wrong with me? No? I'm perfectly fine. Wow. I'm so glad, buddy. Hey, Dr. Level Up, Dr. Saurav, Dr. Right for Respect. Right for Respect, bhai. Do we know your name? Hey, Dr. Lovely Sahu. Good to be with you. Good evening, buddy. Right. So, kindly allow me to start because today we have less time. I mean, as always, we always have less time. So, we'll start with this topic of trauma. Fine. Now, trauma. So, trauma, it is the third most common cause of death overall and most common cause of death in the patient who are less than 40 years of age. Vikramji, as of now, we cannot comment upon the duration. That depends. That depends. Fine. So let's say somewhere between 1 to 1.5 hour. 1 to 1.5 hour. Yeah, Abhishek ji. Nice name. Tawfiq. Kajol. Kajol Jasjeete. Who's Jasjeete here? Jasjeet Kaur. The Punjabis have their own way of showing love and affection. Medico Anurag ji. Hey, Prerit. Wow, nice name. Right. So it's the most common cause of death in the patient who are less than 40 years of age. So someone who's less than 40 years of age is more likely to die of trauma than any other conditions there. Fine. Now we start with this condition. What is that? This thing is called as non-accidental trauma. You must have read this in forensic medicine as the battered baby syndrome. This is also called as the shattered infant syndrome. Shattered infant syndrome. We commonly we use it the term child abuse. Child abuse. Fine. Now, how will you suspect child abuse? How will you suspect child abuse? One thing, posterolateral rib fractures. Posterolateral rib fractures. Fine. Normally, the rib fractures are anterior, but here the rib fracture will be posterolateral. Fine. Now, fractures of the skull which are running across suture lines, fracture of the skull which are running across the suture lines. Fine. Then the occipital impression fracture, occipital impression fracture, metaphyseal fractures of the long bone. Fine. Symmetrical burns, symmetrical burns. Fine. Now, ever changing clinical history, dubious clinical history. Fine. I mean, you cannot trust the patient who is giving the history, trust the attendant of the patient who is giving history. Fine. Symmetrical burns, then the rope marks of being tied around. I mean, the maid will tie the child, so there will be rope marks. Fine. Now, human bites could be there. Fine. Bruises or wounds in the shape of the object. The child will not make eye contact with the patient who's brought the patient. Thank you, buddy, Dr. Manoj Raja. Thank you, Dr. Deep Deol. It was yesterday, Pradeep ji. It was yesterday. I can count the number of drinks I had. Yes, around 7 or 8. How correct you are. That's exactly the kind of drinks I had. Now, you see, this is what we call as metabolic response to trauma. Metabolic response to trauma. So 3 phases: ebb, flow, and recovery phase. Ebb, flow, and recovery phase. Fine. Now you see here, ebb phase will last for few hours. You have to remember what all decrease. If you cannot remember what all decrease, just remember what all will increase. You see, catecholamines, anxiety, stress. Fine. So stress hormone cortisol will increase, aldosterone will increase, adrenaline and noradrenaline will increase. Fine. Now, you see here, in this phase, what happens is that level of insulin, this question has been asked, level of insulin will decrease because, it is a time to spend. Thank you, buddy. Thank you. Saurabh, we'll crack jokes some other time. You can always call me and then there will be series of jokes. Fine. Now you see here. So this question has been asked. Now what happens in the catabolic phase? So that will last for 3 to 10 days. What you need to remember here is that even though the level of insulin increases, but insulin resistance develops. That is what you need to remember. So anyone who's had undergone trauma, he's likely to think of anything, but he won't think about sex. Fine. So that means the levels of testosterone will decrease. Fine. Now, this anabolic phase, this is called as phase of positive nitrogen balance, because body is busy in recovering the lost proteins. Body is busy in making up new proteins. So anabolic phase, which may last up to 2 months, that is called as phase of positive nitrogen balance. Fine. So growth hormone levels will increase. Fine. See here. And this is all what you get to see in trauma. But only the things which I have told you, they are important. Now you see, insulin levels fall. So that means glucagon level will increase. Now these things naturally, interleukins, tumor necrosis factor, they are the result of inflammation. So that means their level naturally, they will increase. So if we want to sum up, fine, what do we need to sum it up? That means the insulin levels, they decrease. Fine. Testosterone levels, they decrease, and aldosterone, which is a stress hormone. Fine. Catecholamine, these levels, they will increase. Fine. This is what you need to remember about the metabolic response to trauma. Fine. Metabolic and humoral response to trauma. Fine. Now, we'll see how do we assess a patient of trauma. So must know that the equation is changed. Another C is added. Fine. So C is to control any exsanguating external hemorrhage if present. Exsanguating, that means the hemorrhage, the kind of bleeding which has the power to drain all the blood out of the body. For example, carotid artery is injured. Yeah, Dr. KSR party will be there. You clear the exam, come to my place. I told you that the fridge is full of beer and we can always have a party. Fine. So, let's say your patient's carotid artery is injured. Fine. In that case, before you take care of the airway, you should stop this bleeding because your patient can die from bleeding. Your patient can die from bleeding. Remember that the platinum 10 minutes. What are platinum 10 minutes? These are the first 10 minutes after the paramedics arrive at the scene of accident. Fine. Now, platinum 10 minutes. Fine. The first hour is called as the golden hour. First hour is called as the golden hour. First hour is called as the golden hour. Why is this so? Why is this so? Why? Because you see, 50% of the trauma deaths, they occur within seconds to minutes, and one cause could be massive hemorrhage, other cause could be massive head injury, fine, or massive hemorrhage. Rest of the 30% of the death, they occur within few hours, they occur within few hours. And here also the common cause is hemorrhage. 20% of the deaths, they occur later. That is why, keeping this thing in mind, what has happened, that the ATLS 10th protocol, advanced trauma and life support, fine, what does it recommend? That 1 liter of IV fluid. Which IV fluid? Crystalloid. And this figure is 20 ml per kg in children. 20 ml per kg in children. This can be given to the adults presenting in trauma. Also, if you suspect that your patient is actively bleeding inside, how? If the systolic blood pressure is less than 90 millimeter of mercury, fine, and if the heart rate is more than 110 per minute, then what you should do, you should give your patient injection tranexamic acid. 1 gram stat intravenously, and this should be repeated after 8 hours. If you suspect that your patient is bleeding, don't hesitate to give your patient tranexamic acid, fine, because there could be some covert injury. Remember London sign. What is London sign? London sign is patterned bruising. For example, there are truck tire marks. Fine. There are some marks of a heavy object falling on the patient's body. Patterned bruising. Fine. So this increases the chances of hidden injury in the chest and abdomen by 3 to 4 times. London sign. If there is patterned bruising present over the chest, that means there can be some internal injury which is not visible as of now. Fine. So after this, following the dictum of ABCD, fine, we move to the airway. Fine. So here, airway, you can use lemon airway assessment. So lemon is basically just a mnemonic. Fine. So first, you look externally. For example, if is there any kind of facial trauma? Why do we want to look for facial trauma? Because we know that mid-face fracture is a contraindication for endotracheal intubation. Mid-face fracture is a contraindication for endotracheal intubation. Fine. Now, all the other factors, they can make the endotracheal intubation difficult. Now, this thing must be taught by the anesthesia teacher also, but let's have a quick look. What is the 3-3-2 rule? Fine. Now, you see here, first, 3 fingers like this. So this is how we are measuring the incisor distance. See here. That means we are checking how is the mouth opening. Fine. Now, mentum to the hyoid bone. Fine. You see here, this distance we are talking about, this should be at least 3 finger breadth. 3 finger breadth. Thyromental distance. Fine. Thyromental distance, that is from the larynx to the base of the tongue. Fine. So this should be at least 2 finger breadth. At least 2 finger breadth. Fine. So this is the 3-3-2 rule. Then you should see the 3 finger. Fine. Both incisor. Fine. Then you see here thyromental distance. Fine. To the base, here is the base of the tongue. Here is the thyroid cartilage. So this should be at least 2 fingers. Then see here. So they might ask you in the examination as an image-based question, what is this distance and why this distance is important? This distance is important to measure the ease of intubation. While you are trying to secure an airway, fine, you may not be able to insert the endotracheal tube. Then you may have to do surgical airway like cricothyrotomy, like tracheostomy. Thank you, Dr. Vaishali. Fine. Now, next is the Malampatti score. Malampatti score. So you see here in the 3 and 4, intubation will be difficult. Intubation will be difficult. You cannot insert a tube blindly. You cannot insert a tube blindly over here. The 3 and 4. Fine. Malampatti score. Fine. You check if there is any kind of obstruction, if there is any kind of obstruction to the endotracheal intubation, and then you check for the neck mobility. One thing which you should always know, that airway management should be done by stabilizing the cervical spine. Should be done by stabilizing the cervical spine. It should always be stabilized first. Fine. Now, which collar do we use for stabilizing the cervical spine? The Philadelphia collar. If you suspect that there is injury to the cervical spine, fine, use the Philadelphia collar. Fine. Next, you should check your patient by following the Canadian cervical spine rules. Canadian cervical spine rules. Fine. So, what do you want to check over here? If you suspect that your patient has cervical spine fracture, then what you should get done? Radiography. That means you should get the X-ray done. But that is a time-consuming process. So what you do is you watch your patient clinically. If your patient has no risk factor, fine. If your patient has no high risk factor, then you can proceed to the airway management without getting the X-ray done. Without getting the X-ray done. If your patient has any high risk, fine. For example, see here. If your patient cannot move their neck, get the X-ray done. Get the X-ray done. If your patient has any high risk factor, for example, you see here, if it is a low risk, let me just show you here. If it is a low risk, it would be high speed collision, not the simple rear end motor vehicle collision. If it is a simple rear end motor vehicle collision, fine, you can avoid. Fine. But if it is a high speed collision, you should always get the X-ray done. What you need to remember here, if they ask a difficult question, they will give you any of the risk factor, and believe me, you will be able to check if your patient has cervical spine injury. For example, I am your patient. If I have cervical spine injury, I won't be able to move my neck. If you as a doctor touch my spine, there will be tenderness. Fine, there will be tenderness. There could be a hematoma over here. I may not be able to move my arms. I may not be able to move my legs. Fine. So clinically, you will clearly be able to understand whether this patient has cervical spine injury or not. Just you need to remember the name. Canadian cervical spine rule. Canadian cervical spine rule. Also, you can use the nexus criteria. The nexus criteria. This mnemonic you can remember. If there is neurological deficit, fine. Ethylene alcohol, that means alcohol poisoning, intoxication, fine. If there is extreme distracting injury, if the patient is unable to provide history, if there is spinal tenderness, then you should get the x-ray done. But mind you, let's make it very clear. Philadelphia collar is a hard collar for stabilizing the spine. Philadelphia collar is the name. Thank you, Dr. Pradipanji. Philadelphia collar is just the name of a hard collar which is used to stabilize the patient, which is used to stabilize the patient's cervical spine. Guddle airway. This is also called as oropharyngeal airway. Oropharyngeal airway. So it is color coded according to size, and just for a matter of relief, you don't need to remember the colors over here. Fine. You see here, this is how we insert the oropharyngeal airway, also called as the Guddle airway, also called as the Guddle airway. Fine. Now these, in 2 years ago in the NEET MDS, they did ask you this. They did ask the parts of the endotracheal tube, bevel. Fine. This is one you should remember. The Murphy eye. This is what you should remember. Pilot balloon was asked in that examination. Balloon was asked in that examination. They might ask you the name of this curve. Another thing which you should notice is that this has got a radio marker lining to see whether the tube is accurately positioned or not. Now you see what kind of intubation is this. This is orotracheal intubation. Fine. This is nasotracheal intubation. Fine. Now, Salix maneuver. What do we do with Salix maneuver? We give a pressure on the cricoid that will make the endotracheal intubation. That means that will make the passage of the tube very, very easy. Salix maneuver is pressure on the cricoid. If nothing works, then you will have to secure the airway surgically. How? Seldinger cricothyrotomy. This is how you have to perform cricothyrotomy. So cricothyrotomy is avoided in children. Why? Because cricoid is the only cartilage that supports the trachea. So your patient has the risk of tracheomalacia, and your patient has the risk of subglottic stenosis also. So cricothyrotomy is best avoided in children. Fine. Now, if you are not able to do tracheostomy or cricothyrotomy, then what you should do is needle cricothyrotomy. Now, needle cricothyrotomy can be done for 15-20 minutes only. Why? Because after that hypercarbia rapidly develops. Fine. So it can be done for 15-20 minutes only. This is the skin incision if you are performing surgical cricothyrotomy. Fine. So this is how you manage the airway. If nothing works, in that case, what you have to do is tracheostomy. Fine. Now, after A comes B, that means breathing. Fine. What do you want to look? Rate, rhythm, and pattern of breathing. Why? Because tension pneumothorax, open pneumothorax. Fine. Tension pneumothorax, open pneumothorax, flail, chest. Fine. So they are considered a clinical diagnosis. They are considered a clinical diagnosis, and they require immediate treatment. We should not waste any time on the radiological confirmation. Fine. Now C stands for circulation. C stands for circulation. This is important there. What are the indicators of shock which you should look for in the patients of trauma, agitation, confusion? Fine. Tachycardia. Fine. Now, weak distal pulses. Distal Weak distal pulses. Fine. Now, you should be using 18 gauze. How many? Two. 18 gauze cannulas, the green colored ones. 18 gauze cannula. Fine. Now, alternatively, what you can do is you can use venesection. Alternatively, you can do the central venous cannulation. And which vein is used commonly? Internal jugular vein. I'm so sorry, buddy. The speed. I want to deliver you the maximum. That is why I'm speaking rapidly. Okay, I'll try to be slow. So sorry, buddy. That has been my problem ever since I started teaching around 10-12 years ago. I'm really sorry. So where do you insert these cannulas? In the cubital and antecubital vein. I'm really sorry. Dr. Nick, that was Jabardast sarcasm. Fine. Now, Love and Bailey says that you should have permissive hypotension. You should go in for permissive hypotension. Permissive hypotension is that systolic blood pressure should be below 70 millimeter of mercury. But if you suspect brain injury, systolic blood pressure must be kept more than 90 millimeter of mercury. Fine. Now, in the situation of dire emergency, you can use 2 units of O positive blood, but females who are pregnant and in the reproductive age group, fine, they should receive only O negative blood. Fine. You can perform whole body CT scan. Fine, to check the cause of hemorrhage. Now this, is equal to 75 chest x-rays. Radiation dose is equal to 75 chest x-rays. If required, your patient can be given massive transfusion protocol. That means packed cells, plasma, fresh frozen plasma, and platelets. They can be given in 1:1:1 ratio. Fine. How do you check whether your patient requires blood or not? You need to check the TASH score. You need to check the McLaughlin score, TASH score and McLaughlin score. Fine. Now, D stands for disability assessment. You do it with the help of Glasgow Coma Scale. D also stands for digital rectal examination. That means you should check the sphincter function. That is also for spine injury. Digital rectal examination. If pelvic fracture is suspected, if pelvic fracture is suspected, if pelvic fracture is suspected, two things. Always your patient must have a pelvic binder and no digital rectal examination, because you can cause membranous urethra injury. So if you suspect your patient to be suffering from pelvic fracture, don't do digital rectal examination. E stands for exposure of the patient. E stands for exposure of the patient. First of all, log roll, I'm really sorry, log roll is not recommended. Log roll is not recommended anymore. If at all it is performed, it should be performed by minimum 4 persons and 5 persons if a limb is fractured, and 5% if a limb is fractured. Fine, 5% if the limb is fractured. Remember, you have to prevent hypothermia while you have exposed your patient, so hypothermia should be prevented, right? Now, if you are doing this as a part of triage, I mean, everything is same. Even if you are attending one patient, the patient should be attended like this. Even if you are attending multiple patients, he should be attended like this. All the patients should be attended like this. So in the situation of mass casualty, what you follow is triage. That means the patient who have maximum chance of survival, they are attended first. Those patients who don't have any chance of survival, they are not attended, because we are not going to waste time on them. Let's say there's a patient who has head injury, chest injury, abdomen injury. Fine. Even with the best of the effort, we may not be able to save that patient. Fine. Time is much important in the situation of trauma. Fine. So what you do is you give your patient tags. Red tag is for those patients who require immediate attention. For example, respiratory rate is more than 30. Your patient is not able to follow your commands. Fine. And heart rate is more than 120. So these patients are the one who should be shifted first of all to hospital. So they have priority in being shifted to the hospital. Just a minute. This is what they are performing. Log roll 1, 2, 3, 4. Fine. So they will do it simultaneously. What is this? London sign. Remember the truck tire marks, pattern bruising. Fine. Seatbelt injury can cause chance fracture of the spine, sudden flexion. Fine. It can also cause the rib fracture, 4th to 7th rib. See, triage. So these are the color-coded bands which are given to the patient. Now these, I told you, red category patient, they are the first to be shifted to hospital. Thank you. C, A, B, C, D. Yeah, that's what I'm saying. Yes, that's what I'm saying. CABC. The situation is CABC now. Fine. Don't confuse it with CAB of CPR. In CPR, you have to, this was given by American Heart Association in 2015. Now that is for CPR, CAB. Here, what we are doing is CABC. So CABC is used in trauma. CAB is used in cardiopulmonary resuscitation. Fine. Now, Yellow tag patient are the patients who require urgent attention. Urgent attention. Fine. For example, open pneumothorax. Fine. Green tag are the patient who require delayed attention. Who require delayed attention. Fine. And then white tag who don't require any medical attention except maybe first aid, so black tag are the patient who are dead or moribund. Fine. That means even with the best of your effort you won't be able to save this patient. Fine. Now in some European countries they use blue tag. So blue tag is given to the patient who just require expectant management. Fine. They are alive, but they may not survive. We expect that they will die. Fine. So blue tag is for those. Blue tag is for those. Fine. Now, so investigation, coming to the investigation, what you should get done, the x-ray chest. Again, as I told you, AP view is important because of the fracture of the bone. They are best seen, on the x-ray. Fine. CT, I've already told you, you can go in for whole body CT scan. Fine. You can go in for ultrasound, that is fast focus assessment with sonography in trauma, and this can be done in just 2 to 4 minutes. Fine. Now, any cerebity, I'm not aware of that, to be very honest, because there's a lot of difference between the cup and the lips. Fine. So till the time the notification comes, we cannot say whether it will be implemented or not. So secondary survey. What is the purpose of secondary survey? That is used to treat non-life threatening injuries. So we check if the patient has any allergy to any kind of drug, whether the patient is taking any kind of medications. Fine. Past medical history. Fine. Pregnancy. Many a time I get the question, sir, P in the ample stands for past medical history or pregnancy. Remember, ample is just a mnemonic. This is not a dictum. Fine. Last meal. Fine. Events of the accident, whether your patient is able to tell you how did he sustain the injury or not. How did the patient sustain injury or not? Fine. If he's able to tell you, that means the brain injury is practically ruled out as of now, at least. Fine. At least it is not a severe injury. Fine. Now we will be moving to the trauma scoring system. Fine. Trauma scoring system. And remember, in the revised trauma score which was given by Champion, they just ask you the parameters: systolic blood pressure. Fine. Then you check what is the respiratory rate of the patient and what is the GCS score of the patient. So these three variables are there in the revised trauma score. Minimum score 0, maximum score 12. That is the other question which they ask. Fine. GCS, the Glasgow Coma Scale. Oh my God, what a big score it is. Fine. Now, what is the first thing they ask in GCS? That how do you check your patient? How do you assess your patient on GCS? Fine. So this is the order. We check if there are any factors which are interfering with our assessment. For example, there could be so much noise around. We try to calm down the relatives of the patient, that please let me assess the patient. Fine. So first is check. Then we see, without disturbing the patient, we just watch the patient. Fine. That is observe. If we say that patient is not having any, it is not showing any signs, then we stimulate the patient. And ultimately, after we have done this, then we are going to rate the patient. So stimulation, see, this is the one which you should be looking for in the examination. Stimulation could be either, verbal stimulation, spoken or shouted request, physical. Remember, no pain is to be given to the patient. No pain is to be given to the patient. We have to give some pressure on the fingertip like this, trapezius squeeze or supraorbital notch. No pain, just pressure. No pain, just pressure. And ultimately, we rate the patient. So check, observe, stimulate, and then rate. Check, observe, stimulate, and then rate. Fine. Now you see what we get to see is 4 eye signs. Fine. 5 verbal sign and 6 motor sign. 4 eye signs, 5 verbal sign, and 6 motor sign. If you can take the screenshot, please do take the screenshot. Fine. Because the clinical scenario based question, this part, whatever is left of this line, that is extremely important. Due to the paucity of time, I cannot go into so much details. Fine. But this left part, whatever is left to this, can you guys take the screenshot? Someone please let me know. This part is extremely important. Fine. So everything left to this line, you should read these lines at least. Fine. Now the next thing which you can see over here is that a new variable has been added, that is non-testable. For example, if your patient's eye have bandage, you're not going to say that the patient cannot see, patient cannot open his eyes. You're going to write non-testable. If your patient has endotracheal tube in place, again you are going to write, thank you, Dr. Sikandar. And this will be labeled as vocal not testable. This will be labeled as eye not testable. Fine. Let's say your patient has arms fractured. He cannot move even with the best of the efforts. Fine. Then you are going to write motor not testable. Motor not testable. Fine. Again, this is what you get to see on the eyes. Fine. Eye opening. Best will be 4. Fine. And least will be 1. And if it is caused by or closed by local factor, for example, bandage, you will write not testable. Not testable. Again, the same. Factors interfering with communication. There's too much of noise around you. Your patient is deaf and dumb. Your patient is having any kind of endotracheal tube in place. Fine. Then you're going to write VNT, verbal not testable. Remember this thing. Single words. This is important. So if the question says your patient can speak some words, fine, then you're going to write 3. You're going to rate the patient as 3. Fine. Now, your patient is quite kind of confused. Fine. Rating of 4. If your patient can answer all your queries, maximum rating like this. Fine. Similarly, for the best motor response, remember in the clinical scenario, you can get this. Obeys 2-part request. Show me where the fan is. After that, show me where the tube light is. Fine. That is 2-part request. Fine. Now, brings hands above the clavicle. That will be localizing the pain. Again, not localizing the pain, localizing the pressure. Fine. 5 will be the score. Fine. Now, you see here. This is normal flexion. Normal flexion. Bends arm at the elbow. Fine. Now, abnormal flexion. Bends arm at the elbow, but is abnormal. Let me just show you what is abnormal. See here. Abnormal flexion. Fine. Abnormal flexion. Like this. Fine. That will be abnormal flexion. So they might show you this picture. They might show you this picture. Fine. Now, abnormal flexion is similar to decorticate posture. Abnormal extension is similar to decerebrate posture. Decerebrate posture. Fine. Again, this fingertip squeeze. That is how you give the pressure. Trapezius pinch. Supraorbital pressure. This is how you stimulate. This is how you stimulate the patient. Stimulate the patient. Fine. Now, So GCS, if it is 15, that means it is just a minor brain injury. It is just a minor brain injury. 13 to 14, mild. 9 to 12, moderate. 8 or less than 8, severe injury. So this patient will require endotracheal intubation. This patient will require endotracheal intubation. Fine. Too much of GCS, right? So we are about to end it. PRS, there, that is a new score. PRS. What is PRS? PRS is pupil reactivity score. Pupil reactivity score. Fine. So pupil, I added some of the new slides there. I wonder where are they? So pupil reactivity score. If both pupil are abnormal, pupil reactivity score will be 2. If one pupil is abnormal, pupil reactivity score will be 1. Fine. If none of the pupil is abnormal, that means both pupil are normal, pupil reactivity score will be 0. Now, what is the purpose of pupil reactivity score? Because with the help of this, we can get another score, GCSP score. What is that? GCS score minus pupil reactivity score. GCS score minus the pupil reactivity score. Fine. So this is a better marker than GCS, better marker of the neurological condition of the patient. Now, GCSPA score. GCSPA score is basically GCSP score, which is adjusted according to the age of the patient. GCSPA score adjusted according to the age of the patient. Yeah, exactly. Adjusted according to the, yes, Dr. Sikandar, and yes, Dr. Sikandar, you're right. So GCSPA score adjusted according to the age will tell you the chances of patient having mortality. Let's say your patient is 20 years of age and GCSP score is 7. The chances of your patient dying are around 7%. So 6 monthly mortality it will give. Fine. If your patient is 65 years of age, fine, and the same GCSP score, chances of your patient suffering from mortality are around 30%. Fine. So GCSPA score, GCSPA score. Another thing, if right and left motor scores are different, for example, in the right arm, your patient is showing the score of 4. In the left, your patient is showing the score of 3. 4 should be used for final score calculation. So better motor score should be used for final score calculation, not the lower one, not the lower one. Fine, not the lower one. Right now, another thing which they ask you in the topic of trauma, another thing which they ask you in the topic of trauma is trauma triad of death. Trauma triad of death. So your patient is likely to die of this triad, that is hypothermia, metabolic acidosis, and coagulopathy. So one thing will lead to the another. Hypothermia can develop because of IV fluids, can develop because of sympathetic stimulation, which causes vasoconstriction, metabolic acidosis due to lack of oxygen, coagulopathy, why? Because of hemodilution. Your patient lost 2 liters of blood, and what did you give your patient? Ringer lactate, no clotting factors. So clotting factors will be diluted. Clotting factors will be diluted. So what do you do for this? You do damage control surgery. Damage control surgery is done in three phases. First phase is done in the OT. You just wash the wound, control the bleeding. You just wash the wound and control the bleeding. Fine. Then what do? You send the patient to ICU. You send the patient to ICU so that the condition of the patient is stabilized. Condition of the patient is stabilized. Fine. Then what you do is you take the patient to the OT again for definitive surgery. Fine. And the best indicator here is serum lactate values. Best indicator here is serum lactate values. If they are more than 5 millimoles per liter, then you should always advise your patient. You should always advise your patient to undergo, you should always take up your patient as a part of damage control surgery. Dr. Sikandar, vitamin K, yes, of course, we can give, but the problem is vitamin K effect will start after a few days, what to talk of few hours. It will start a bit late. So if your patient is having coagulating factor deficiency, what is the best thing to do? Fresh frozen plasma. Fresh frozen plasma. Now, again, this is not a trauma patient, but if your patient is to undergo any major surgery, international normalized ratio should be less than 1.4. International normalized ratio should be less than 1.4. Fine. Now, injury severity score. The only thing which they ask is what is the score range. Score range is between 1 to 75. 1 to 75. So, body is divided into 6 regions. So only those 3 regions which have maximum severe injury, they are chosen for further study. Fine. And then every injury is rated according to abbreviated injury severity score. Fine. Now, must keep in mind that if any patient has grade 6 injury, fine, then the score of the patient is set to maximum, that is 75. So that means any patient who has the score of 75 will have most severe injury. Another thing which they ask is that score more than 15 indicates severe trauma. It indicates major trauma. Not the severe trauma. Please allow me to get corrected. It is major trauma. Any score more than 15 is major trauma. Dr. Kiran Rajji, colloid means, let's say you are using normal saline. Let's say you are using dextrose. Let's say you are using, these are crystalloids. Colloids are hexaethyl starch, pentastarch, hemaxyl. These are colloids. So we call the colloids as volume expanders. What is the problem with the use of colloid? Problem with the use of colloid is they have no oxygen carrying capacity. Fine. And some of the colloids, they may interfere with cross matching of the blood. For example, dextran, it interferes with the cross matching of the blood. Fine. And they remain inside the body for a long period of time. I hope that answers your query, Dr. Kiran Raj. Crystalloids are normal saline, ringer lactate, dextrose, colloids, hexaethyl starch, pentastarch, and dextran. Fine. Now, very quickly about the rib fracture. So most of the rib fracture, how much? 90% of the rib fracture will affect 2nd to 7th rib. First rib, because it is protected by the clavicle, this fracture is extremely rare. Right? You see here is the clavicle covering the ribs. Fine. Now, so what is the treatment of the rib fracture? You have to do the pain management. You have to do the pain management. Fine. What are we worried about here? What is this? This is intercostal nerve block. You can use as a part of treatment. You can use as a part of the treatment for pain. Now, this is the normal physiology of inspiration. Please note that at the time of inspiration, the chest expands. At the time of expiration, the chest wall constricts. See here. You see, this is inspiration. This is expiration. The point I'm trying to say is at the time of inspiration, the pressure inside the chest is low. At the time of expiration, the pressure inside the chest is high. See, the diaphragm is going down, the chest wall is going out at the time of inspiration. At the time of inspiration. Why am I showing you this? Because we are going to discuss the flail chest, fracture of 3 and more than 3 ribs at 2 or more than 2 points. What point did I miss? Fracture of 3 and more than 3 consecutive ribs. It could be 3, 4th, 5, 3rd, 4th, and 5th rib, 7th, 6th, and 8th rib. Find consecutive ribs. Now, at the time of inspiration, what will happen? The flail segment will go inside. Flail segment, the broken ribs, they will go inside. At the time of inspiration, all the ribs are coming out, but the flail segment will go inside. This is called as paradoxical breathing. Paradoxical breathing means against the rules. Fine. Paradoxical breathing. See, paradoxical breathing. At the time of inspiration, the chest wall which is fractured is going inside rather than coming out. It is going inside. See, you can see the chest wall going inside at the time of inspiration and coming out at the time of expiration. Right? Now, what is the treatment here? No strapping. Remember, flail chest has been moved out of the list of life-threatening injuries. Fine. Now, the most common cause of death in the flail chest is associated tracheobronchial injury. It is not pendulift anymore. Pendulift is no longer considered to be the most common cause of death. Most common cause of death is tracheobronchial injury. Fine. Now, most of the flail chest can be managed by simple oxygenation. Fine. If required, you can do intermittent positive pressure ventilation. Fine. And rarely you might be required to do the surgical fixation to the normal ribs above and below. Fine. Now, along with this, you can use double lumen endotracheal tube. I'll just show you when the time comes. I mean, it's there in this PPT only. I'll just show you, don't worry. The double lumen endotracheal tube. Now, you see, what is this? If any part of the lungs rupture, it will give rise to closed pneumothorax. That means there is no external wound, but free air is present in the pleural cavity. Closed pneumothorax. Sometimes what may happen is your patient may be stabbed in the chest. That will be called as closed pneumothorax. So pneumothorax is presence of free air in the pleural cavity. Fine. Now, It could be closed. That means there is no external wound. It could be open. That means there is external stab wound. And both of them can lead to tension pneumothorax, can lead to tension pneumothorax. Now you can see intense blackening over this area. Now you can also see the collapsed lung. So your patient is suffering from tension pneumothorax there. If the lung is being compressed, that means tension pneumothorax has developed. Fine. Tension pneumothorax has developed. Now you see that's an open pneumothorax which later on developed into tension pneumothorax. There is an external wound, open pneumothorax. You see the lung is compressed on both sides. Mediastinum has shifted to the other side. Trachea has deviated to the other side. Now, if you do the percussion, there will be hyper resonance. There will be decreased breath sounds. Sometimes the pneumothorax and hemothorax both can develop if we want to cannulate the subclavian vein. By mistake, our needle can enter into the lungs. By mistake, needle can enter into the subclavian artery. So your patient can develop pneumothorax both. Again, you can see collapsed lung. Fine. Now, apart from this, your patient will have low blood pressure. Now, just imagine these veins there, Fine. So these veins, there will be decreased venous return, because what I want to show you here is this. See, the veins are compressed, so there will be decreased venous return. That is why there will be hypotension. Hypotension. Fine. Now, you see here, again, this is the lung. Have a look at this for 10 seconds. At least for 10 seconds. The helpful doctor bete. Closed pneumothorax. Let's say you're doing intermittent positive pressure ventilation. By mistake, you apply too much force. Lungs will be ruptured. Fine. Whatever air is going inside through the nostril will be collected in the chest, but there is no external wound. So that will be called as closed pneumothorax. This is how you do. This is called as three-seal dressing. See, three-seal dressing. At the time of inspiration, it will not allow the air to go inside. At the time of expiration, it will allow the air to escape. Three-seal dressing. See, this is three-seal dressing. Now, first of all, you have to insert an intercostal tube. Fine. Two things. It should not be inserted through the wound. It should not be inserted through the chest wound. Fine. Second thing, where you should insert. See, first is you insert a needle. You insert a wide bore needle to drain all the air. Fine. So it is different for adults and for children. So in children, the needle is to be inserted in the second intercostal space, fifth intercostal space, in the mid axillary line, in the mid clavicular line. Now this should be followed by placement of intercostal tube in the fifth intercostal space, mid-axillary line in both children as well as adults. So the placement of needle is different. Placement of needle is different in children as well as in adults. Fine. Well, it is the same. You see, I told you that we have the picture of double lumen endotracheal tube. So if you want to inflate one lung more than the other, you can use double lumen endotracheal tube. So this can be used for flail chest also. Hemothorax can occur because of tumor, can occur because of trauma. Fine. Can occur because of central venous cannulation. Remember, you were inserting a needle in the subclavian vein. That can also give rise to hemothorax. Presence of free blood in the pleural cavity. So only about 7 ml of fluid is present in the pleural cavity. If free blood is present, then what you can do is you can check either by the X-ray. You see here, free blood is present, and minimum 350 ml of blood should be present before it can be detected on chest X-ray. While if you perform the E-fast, which is a type of ultrasound, even 2 to 4 ml of free blood can be detected. That's the difference between X-ray and ultrasound. But if you perform lateral decubitus X-ray, then as little as 50 ml of blood can be detected. Yes, Dr. Vishnigam, stab injury can cause open pneumothorax. See, this is hemothorax again. The white color thing is the blood. Now, in cardiac tamponade has to be differentiated from tension pneumothorax. So, in tension pneumothorax, there will be decreased air entry. Fine, every other clinical feature will be same. But what do you get to see in the cardiac tamponade? First of all, these are the causes of cardiac tamponade. The common cause is trauma, direct trauma. Fine, you are doing any kind of invasive procedure on the heart around the pericardium. In that case, you can damage the myocardium. Fine. Pericarditis, neoplasm or malignancy. If you say that I don't want to remember this much, just remember this, trauma. Fine. And just remember this, uremia. Fine. Renal failure. Right. So these are the causes. What are the clinical feature? Beck Triad. What is the mnemonic? MDH. Fine. So MDH, there will be muffled heart sounds because the blood is coming, the sound is coming out through the column of blood. There will be distended neck veins and there will be hypotension. Remember, it has to be differentiated from tension pneumothorax. So this is an important question. There will be absent breath sounds in the tension pneumothorax. Fine. And there would be muffled heart sounds in the cardiac tamponade. Collection of free fluid in the pericardial cavity. Now, abdominal trauma. If there is penetrating trauma and you see the omentum protruding out, indication for laparotomy. Open the abdomen and see. If the dressing is stained with bile or stools, fecal matter, it is an indication for laparotomy. If the peritoneum is not cut, treat the wound as lacerated wound. No need for laparotomy. Fine. Now, if your patient of abdominal trauma is stable, That means blood pressure, heart rate, everything is in normal range. Fine. First investigation is ultrasound, that is fast. Second investigation is contrast CT. If your patient is, unstable, then you can go in for fast or e-fast. Fine. Only ultrasound is available. Only ultrasound is available. You cannot do two investigation over here. You cannot do two investigations over here. Fine. Now you see here. Can you see CT scan? Here is showing this white colored thing. What is this? This is the contrast leaking out from the liver. Contrast leaking out from the liver. Contrast leaking out from the liver. Now you see, liver is practically divided into two parts. It is showing a massive liver laceration. Right. Now, in the fast, what you do is you have to check four areas. Again, perihepatic, pericardial, perisplenic, and the pelvis. And if you draw this line over here, so what is this? E fast, extended fast, focused assessment with sonography in trauma. Focused assessment with sonography in trauma. That means you look for the chest fields also. Chest fields also. Fine. Chest fields. Now, what do you get to see over here? Seashore sign. Seashore sign is seen in normal lung. Fine. Seashore sign. Now, if you get to see this on the ultrasound, barcode sign, stratosphere sign, that is seen if your patient has pneumothorax. If your patient has pneumothorax. Seashore sign is normal. Stratosphere sign is abnormal. Presence of pneumothorax. Fine. Presence of pneumothorax. Alternatively, you can do diagnostic peritoneal lavage. Diagnostic peritoneal lavage. Fine. This is how you do the diagnostic peritoneal lavage. Send a catheter inside. Aspirate the content. If more than 10 ml of blood is present, bile, bacteria, food or foreign body is present, more than 1 lakh red blood cells can be seen under the microscope. That means your patient has abdominal injury. Proceed with the management. Proceed with the definitive management. Right. Now, see, in the retroperitoneal injury, specific organ injury, we can discuss some other time. You see here, in the retroperitoneal, because that's kind of time consuming. So in the retroperitoneal injury, we see that retroperitoneum is divided into three zones. Fine. So here, if there is any trauma in zone 1, you see how important structures will be affected. You have to explore every injury. In the zone 2, kidney and colon is present. Explore. Do the surgery in penetrating trauma. In the zone 3, pelvis, you have to explore only the expanding hematoma. Fine. That is a retroperitoneal injury. So you see here in the neck injuries, first they ask you the landmark. Suprasternal notch, cricoid cartilage. This is zone 1. Cricoid cartilage to the angle of mandible is zone 2. Angle of mandible to the base of skull is zone 3. Most serious injuries occur here. Most common but least serious injuries occur in the zone 2. Internal jugular vein can be injured in the zone 3. Fine. Now, there was a mnemonic there in the Leaford fracture. Fine. So in the Leaford fractures, what was the mnemonic? I forgot. Yes. Gandhiji, 3 monkeys. Don't speak evil. Fine. Don't see the evil. Don't hear the evil. Don't hear the evil. So this is Lee Fort 1, 2, and 3. Fine. So you see, the jaw will be affected. Fracture will be reaching the orbit. Fine. Now you see here, skull and the face will be totally separated in the Lee Fort 3 fracture. You will just be asked to identify the pattern. Fine. 2, it has got pyramidal shape. 2 has got pyramidal shape. This is how you can remember, or the 3 monkeys of Gandhiji. Now, this thing is very important there. Again, if you want to take the screenshot, if you don't have. Dr. Shiru, the white dog, what was that? I'm not done with you guys yet. Just give me a minute. Now you see, what do they ask in the brain injury? What do they ask in the brain injury? Fine. First, what is the mechanism of injury? Fine. Now you see, in these cases, the stationary head will be set into motion. So what are they? Accelerating. What is this? Decelerating injury. Moving head will come to a sudden rest. Coop, the area of the brain directly under the attack. Contour coop. This is how the contour coop injury occurs. See, contour coop injury occurs. Better image available. See, the contour coop injury. Now, what you should be aware of is this. Extradural hematoma will be associated with a fracture. Common artery to bleed is middle meningeal artery. Why? Because it lies below the pterion, the thinnest part of the skull. Pterion. Fine. Skull fracture bleeding will be from the middle meningeal artery, so it will compress the hematoma. What do you expect? Lucid interval. Patient can die. Whereas subdural hematoma, bleeding will occur from the dural veins. This is common in young. This is common in elderly. Again, this is the difference. Fine. So this will give rise to biconvex hematoma. The extradural hematoma will be biconvex. The subdural hematoma would be like this: plano-convex or concavo-convex. Fine. See here, on the left side is subdural, on the right side is extradural. Arterial blood is pressing the brain. Fine. So investigation of choice in head injury. What is it going to be? Investigation of choice in head injury will be non-contrast CT. Why? Because the MRI is time consuming. You might have to use contrast in MRI. Fine. So that is why it is not recommended. Non-contrast CT will give you quick result. Fine. Now, the subarachnoid hemorrhage, most common cause is trauma. Most common cause of spontaneous subarachnoid hemorrhage is rupture of Berry aneurysm at the circle of Willis. Your patient will say that, doctor, I am experiencing thunderclap headache, worst headache of my life. nausea, vomiting, all these things would be present. Fine. If you get the CSF will be xanthochromic, red colored. Xanthochromic, that is red colored. Fine. What is the treatment? Treatment is supportive management in subarachnoid hemorrhage due to trauma and clipping of the aneurysm or coiling of the aneurysm in spontaneous subarachnoid hemorrhage. So this is extradural hematoma on CT scan. You see convex. You see convex on both sides. Intracerebral hemorrhage is common in middle age, is common in hypertensive. It is a surgical emergency. Clot should be removed immediately. Why? You see, this is appearing white. This you should look for in the in the CT scan images clinical question. Now you see here acute. If there is anything which is acute, that will appear white because that will be dense, made up of blood. If it is chronic, that will appear black because all the blood will be absorbed, only the water will remain. Now you see here, it is the acute intracerebral hemorrhage. That is why it is appearing white. It is appearing white. Now what is this? This is diffuse axonal injury. Now, what question do they ask? This occurs due to shearing force. Gray matter moving over white matter. Neurons will be damaged. Fine. Shearing force. You see here. Shearing force. Shearing force. Now, the next thing which they ask is how to check for it. This can be appreciated. This can be appreciated only on MRI. This can be appreciated only on MRI. Fine. It cannot be seen on CT. It cannot be seen on CT. Fine. This is how the diffuse brain injury occurs. Diffuse axonal injury. Fine. So the neurons, they break. Now, one thing is Cushing triad. Fine. So in the Cushing triad, there will be increased blood pressure, there will be decreased heart rate, and there will be decreased respiratory rate. Why does this thing happen? Why does this thing happen? Let me just show you. Now you see here, because of increasing pressure inside the skull, cerebrum will be pushed towards cerebellum and cerebellum will be pushed out through the foramen magnum. Because of the irritation of vagus nerve, which is a part of parasympathetic nervous system, there will be decreased heart rate. Because the respiratory center is present in brainstem, there will be decreased respiratory rate. Because the pressure inside the skull is very, very high. Heart tries to match that pressure. So there will be hypertension. In the scenario based question, if you see, thank you, buddy, thank you. If you see that, I hope that's not a sarcasm. If you see that your patient is having hypertension, your patient is having erratic respiratory rate and less than normal heart rate, make sure that you mark your patient to be having brain injury and not hypovolemic shock. You see, if you compare your patient of hypovolemic shock and your patient of brain injury, hypovolemic shock can be seen in abdominal injuries, can be seen in chest injuries. Fine. Now you see here what will happen? Heart rate will be very, very high. Blood pressure will be very, very low because the patient has lost blood. Pulse will be thready in the brain injury. Fine. In the brain injury, heart rate will be low. Heart rate will be low. Respiratory rate will be high because of anxiety. Fine. Heart rate will be low. I told you why. Because of the compression of vagus nerve. Fine. Respiratory rate will be low because of compression of brain stem. Compression of brain stem. Fine. Now, pulse rate we have discussed, fine, and then the blood pressure will be very high because body is trying to match the pressure inside the skull. Body is trying to match the pressure inside the skull, and pulse will have normal volume. So this is how you can differentiate the brain injury and head injury in the clinical scenario based questions. Now, you see, this is your subdural hematoma. This is the lens shaped extradural hematoma. Now, one thing more that how to differentiate between a black eye and a raccoon eye, which is also called as panda eye. So this can be unilateral or bilateral. This is more commonly bilateral. Black eye will appear immediately. So this comes with significant delay of few hours. So usually it is not associated. It is not associated with other injuries. So this is associated with base of skull fracture. Which part? Anterior part. Anterior part. Fine. Here you will see uniform blackening. Here you will see tarsal plate sparing. Very important sign. See, uniform blackening. Everything is black right up to eyelashes. Here, what you will get to see, that area around the eyelashes will not be black. Fine. Now, this is seen in the anterior part of the base of skull fracture. If it is middle part, you will get to see bruising around the mastoid. Fine. That is called as battle sign. Neat PG, this was asked. Fine. And you see here, I mean, last to last year. Now, you can also see hemotympanum, basilar skull fracture. Now, what is seen in the posterior basilar skull fracture? Visual field defects. You also get to have Wernicke syndrome. Last four cranial nerves, they will be paralyzed, significantly paralyzed. Fine. That is what you get to see in the posterior basilar skull fracture. Fine. I don't wish to extend the lecture too long, so I'll request sir, maybe he can give me another class, and if you guys wish to attend, you can attend that class. Rest of the thing we'll discuss in the next class, if I get any. Fine. So now I want to keep some time for your queries also. If there is any query, please do ask me. Again, I'm really sorry because of the pressure I have. I mean, because of the pressure coming from inside. I want to deliver you the maximum possible. So that is why sometimes I make this mistake. Sometimes I make this mistake of going a bit too fast. I understand that could be problematic. When we go too fast, we are not able to deliver the best. I mean, deliver the best possible. So I'm waiting for your queries. No, no, trauma is over. Yeah, yeah, yeah. Trauma, Dr. Mithila, mesentery, in fact, is the most common injured organ, they used to say. Fine. But if we are talking about the solid organ injured, now it is the spleen. No, Dr. Katir, we are done with the trauma. Helpful doctor, if your patient is stable, the first investigation will be ultrasound, that is the fast. The definitive investigation would be contrast CT. If your patient is unstable, only fast needs to be done. Dr. Katar, what is left in the topic of trauma? Uh, Maybe the abdominal, specific abdominal organ injuries, but I don't think they are very important there. I mean, they're not going to ask so deep into the topic of liver. For example, let's say if they ask you in the topic of liver, what will they ask? They will ask you only about the Pringle maneuver. Pringle maneuver, in Pringle maneuver, what you do? You press the hepatoduodenal ligament, and then all kind of bleeding will be controlled except the bleeding from hepatic veins. Fine, that is what they ask. And yes, that in the grade 3 injuries, we do selective non-operative management in the spleen. Fine. Again, they ask you that, specific organ injuries. Some of the questions I'm listing. Membranous urethra injury is common with pelvic fracture. Fine. Bulbar urethra injury is common with saddle injury or any kick to the perineum. Any kick to the perineum. Fine. Now, in bulbar urethra injury, you will get to see perineal hematoma. You will get to see blood at the tip of the meatus. Fine. And naturally, your patient won't be able to pass urine. Treatment in both, is to do suprapubic cystostomy. Suprapubic cystostomy. See, naturally, we know that O negative blood is the preferred blood, but the problem is O negative blood is available very, very rarely. Fine. So, in the situation of dire emergency, you are going to use O positive blood. But if the female is pregnant, if the female is in reproductive age group, we will always go in for O negative blood only. Dr. Vishnegam, lucid interval, first of all, it is present only in one third of the individuals. And if it is present, there are chances of your patient dying. There are chances of your patient dying. So there's no, percentage of wise that what are the chances, but yes, your patient can die. So I'm waiting for your queries. Uh, Abdominal compartment syndrome. I don't think so. Abdominal compartment syndrome, they might ask you the causes, retroperitoneal hematoma, fine, distension of the abdomen. These are the important causes. How do you measure with the help of Foley's catheter? Fine. And when do you want to release it? Like when it is more than 12 centimeter, you say your patient is suffering from abdominal hypertension. I don't think this is important. They're not going to go too deep. Subdural hematoma, the treatment is, I did show you this, but I did not speak up. Just a second. This is how you do burr hole drainage. Subdural hematoma. The treatment is burr hole drainage. Burr hole drainage. The helpful doctor, please don't go in for. I don't think this is important. The abdominal compartment syndrome. Right. So, can you allow me to end the class? So, I was just taking up the queries, and not many queries are pouring in. So, maybe I can stop the streaming. I said I can stop the streaming. Okay.